Okay, we can
Okay. Okay, welcome everybody for today's Journal Club. We have today the Center of Genova involved in doing this Journal Club, and actually Dr. Giuseppe Ferro is going to be the presenter, and his tutor is going to be Dr. Mickey Long, who actually is the chief.
Okay, can you see it?
Yeah.
Yes, perfectly.
Okay. So I chose for 1 second and I've not started from the start. Okay. Okay. The paper that I chose is a recent paper. If you can please,
Sorry, Giuseppe, I think it's from your phone. I think this is coming from your phone.
From my phone?
Yeah. So I can mute all the others because there are multiple, maybe other people connecting with your account.
Yeah, it might be that people are connecting and they didn't turn off their
okay. We should
okay, so now it's okay. Now it's okay. Okay, so I chose a recent paper from the Congenital Heart Surgery Society in North America, which analyzed the outcome after either Norwood or comprehensive stage 2 procedure in patients who were previously palliated with hypoplastic for hypoplastic left heart syndrome and similar. Let's first start to define what are we talking about. We call it hybrid procedure, a procedure which involves left and right selective pulmonary artery bending plus ductal stent. In case that the stent is not placed, children are kept on prostaglandins till their stage 2 procedure, which can be either a Norwood procedure, which consists in aortopulmonary root amalgamation associated to a shunt, which can be either systemic, like a modified BT shunt, arterial pulmonary shunt, or it can be a RV to PA shunt, like ECHSA shunt. We call it comprehensive stage 2, a procedure which includes a Norwood type arch reconstruction and a bidirectional gland, and is usually performed later in life, within the first year of life, usually at 5-6 months of age. So the paper actually analyzed, included 23 institutions in North America, United States and Canada, and all patients we had a hybrid retardation who were bended plus or minus ductal stent, and after that they analyzed their outcome. So there was a total of 214 patients in a 15 years period, which is about 14 patients per year. Children, of those 214 patients, 36 children died, 21 had a heart transplant, and 19 had a biventricular repair. So we come to our study group, which consists of 138 patients. Of those 138 patients, 73 patients underwent a Norwood operation post the neonatal age, from 2 months to about 6 months, or a comprehensive stage 2 procedure. In the study group were excluded anatomies like unbalanced IV canal or atrioventricular or ventricular discordance. As you can see from these slides, we see on the top left a graph which analyze the prevalence of the procedures among the different institutions. You can see that the comprehensive stage 2 is depicted in the blue bar, while the Norwood procedure is depicted in the red bar. And you can see that a few institutions, I would say maybe 4 or 5 institutions, did most of the procedure, while other procedures that did only a few, while I say most of the institution did just a few cases in the study. If we take a look at the bottom graph, we see the incidence of either Norwood or comprehensive stage 2 procedure over time. What I think is that after an initial enthusiasm towards the comprehensive stage 2, which was growing in the first decades of 2000, after that there was a return of the Norwood procedure as the more often performed procedures. And this is, as you can see, this includes many institutions. Some of them are big institutions like Hospital for Sick Children, Children's Hospital of Wisconsin, and so on. If you look if we look at the patient's characteristics, we see that Norwood group compared to the comprehensive stage 2 group showed a lower gestational age, so we had more preterm born in the Norwood group. The birth weight in the Norwood group was lower, 2.8 versus 3.2 kilograms, the BSA as well. Also, we can see that there was a more higher prevalence of interrectal communication restriction in the Norwood group compared to the comprehensive stage 2 group. With regard to the preoperative condition, patients in the Norwood group needed mechanical ventilation more often than the patient in comprehensive stage 2, and also needed more interventions on the pulmonary arteries, which were previously banded. That means that those children were probably less stable. They had more comorbidities in the, in the Norwood group compared to the comprehensive stage 2 group. If we look at the operative details, especially at the time of the hybrid procedure, you see that the Norwood group had children, newborns in the Norwood group had more use of cardiopulmonary bypass during their hybrid first stage procedure compared to comprehensive stage 2 group. Also had less stent implanted in the duct compared to the comprehensive stage 2 group, and also atrial septal intervention like atrial stent were less performed in the Norwood group compared to the comprehensive stage 2 group. That means that probably children in the when they got their hybrid at the newborn age, and they were supposed to have to undergo the comprehensive stage 2 pathway, they were kind of more stable, and they wanted them to wait more in order to have their procedure done. So let me see, it's not going on. Okay, if you look at the endpoints at the 5-year survival, you see that patients in the Norwood group had a worse survival with just 65% survival in the first 5 years compared to the patients in the comprehensive stage 2 groups. And also the percentage of Fontan completion was lower in the Norwood group, even though it didn't reach statistical significance. So what they concluded is that the prevalence of factors like prematurity, lower birth weight, and other comorbidities influenced the outcomes in the Norwood group compared to comprehensive stage 2 groups. Children in comprehensive, children were who underwent comprehensive stage 2 procedure were probably more stable. Comprehensive stage 2 procedure was performed in institutions which were used to do that procedure. And as you can see from a previous slide that I show you, many institutions haven't done any comprehensive stage 2. So choice to pursue Norwood West comprehensive stage 2 procedure is influenced by institutional policy, with some institutions doing both, some institutions doing just Norwoods and hybrid when children are deemed not ideal candidates for a neonatal Norwood. So those institutions, they prefer to do hybrid first and then doing Norwood, and other institutions doing just a very few cases. All these parameters and characteristics have influenced outcomes, and I would say have made the results so significant in my mind. So nevertheless, this paper, even though it didn't give me groundbreaking insights, was very interesting because it made me just look at the literature and what happens in North America with regard to this very particular and very difficult subset of patients with hypoplastic left heart syndrome or hypoplastic left heart complex. And I found this slide from the Congenital Heart Surgery database, which shows the number of procedures which were performed at the newborn age in the United States in a 4-year period. As you can see, the most frequent, by far, the most frequent procedure performed at the newborn age in the United States is the Norwood procedure, which is performed in about 10% of newborns, with a mortality of about 14%. If you look at the hybrid procedure is much less performed compared to Norwood procedures, and also gives worse results, especially when it's performed without application of a ductal stent. You see that when it's performed without a stent in the duct, the mortality rises to 32%. So they have a different outcome. When you look at procedures where they are performed in infancy, so I say from the second month to the first year of life, you again see that bidirectional gland is routinely performed in the United States with either a pulmonary arterioplasty or other associated procedure. Norwood procedure, as you can see here, is also performed in infancy in children who previously probably had a hybrid and then they underwent a Norwood procedure. And you can see from this slide, which depicts the 35 most frequent procedures in infants in the United States and Canada, that comprehensive stage 2 is just not there, since it's very rarely performed in the United States. So let's start to define what is a high-risk Norwood, because this is what we are talking about. We are talking about sick children with hypoplastic left heart syndrome, who in some cases are not good candidates for Norwood, and they get a hybrid procedure. So usually we define those children with when they have some characteristics. One characteristic is prematurity, a second characteristic is low birth weight, and then also there are children with congenital anomalies and genetic syndrome who are considered too sick to get a Norwood. Also, the anatomy of the left heart is a factor who might influence the decision to do a neonatal Norwood, to either do a neonatal Norwood versus doing a hybrid and buying time to get a Norwood later on. So when the children have an intact atrial septum or a restricted atrial communication, they have a high risk anatomy, or when they have like an anomalous pulmonary venous return, when they are born with severe TR, with myocardial dysfunction, with coronary fistulas, or with an ascending aortic size, which is less than 2 millimeters. This is a high-risk anatomy group with hypoplastic left heart syndrome. If you take a look at the paper from Philadelphia, it's a kind of an old paper from Children's Hospital of Philadelphia. You also see from these slides that when children are born with intact atrial septum, or restrictive interatrial communication, their outcomes are worse. In general, their outcomes at 1 year are about 30–40% of mortality. So survival is not as high as a standard group. And this is even worse when there is an intact atrial septum with survival, which is only about 20% at the first year of life after the Norwood procedure. If you look at the effect of atrioventricular regurgitation on survival after Norwood, you see that if you got a tricuspid valve which is leaking and you have to do a repair at the newborn age, you're not going to get very good results. And in fact, survival drops to 60%. If you can postpone repair of the tricuspid valve till you get to your Glenn or Fontan, results are better. Also, ascending aorta is a factor influencing outcome after Norwood procedure. When the ascending aorta is lower, is less than 2 millimeters, children that tend to do worse, and they have a survival of about 50% at the first year. In general, survival after Norwood procedure is influenced by risk factors and is not as good in patients with high risk, with a high risk anatomy. When you have, for example, low birth weight, your survival at 1 year is only 60%. When you have regurgitation at the tricuspid valve, is also worse. And when you have anomalies at the atrial septum or at the level of pulmonary veins, survival is not so good, as described in this recent paper from Children's Hospital of Wisconsin. One of the strategies which was involved trying to mitigate this mortality after the Norwood, especially between the Norwood first stage and the second stage in Glenn, has been shown by Dr. Michelon while he was working in London. They kept those children in hospital till after the Norwood, till they get their Glenn, and that showed improved survival, which is about 90% till Glenn after Norwood procedure. This is also related to patients who have anomalies like total pulmonary venous return or intact atrial septum. And in general, can be a strategy trying to have better outcomes in this very high risk group. When you take a look at the comprehensive stage 2 procedure, you know that this procedure was developed in Germany about 20 years ago, and in Gießen. And Gießen has probably the biggest experience with the comprehensive stage 2 procedure. They do routinely comprehensive stage 2 procedure after hybrid procedure at the neonatal age. So far, they performed about 200 patients with hybrid stage 1. Of those, 117 patients got their Fontan, which is about 60–65% of the patients. Their survival has been good, about 77% in a 23 years period. I have to say also, they have described also a 30% percentage of left pulmonary artery stenting. This, introduced me to the next argument. One of the problems that has been shown after comprehensive stage 2 procedure is mostly related to the pulmonary artery reintervention. You see that children, after getting their comprehensive stage 2 procedure, they need more intervention especially in the left PA, as shown here in this paper from the group of Toronto. Also, another paper from Wilmington showed a higher degree of pulmonary artery intervention, either with surgery or with cut after pulmonary artery bending when you compare them to standard Norwood. A group from Columbus, Ohio, which initially was performing many comprehensive stage 2 procedures, looked at their data and they found results which were not ideal. That brought them to a rethinking about the old protocol, and they came out with a new protocol at the time of comprehensive stage 2 procedure in order to reduce their mortality and also the rate of reintervention on pulmonary arteries. Usually they perform the comprehensive stage 2 at age 5 and not before 3 months. They tend not to do emergent comprehensive stage 2 procedures. They do an exit angiogram after the surgery to look at the pulmonary arteries. They have a lot